Okay, hello everyone. It's 11 a.m. In Portland and we'll start the webinar now. Welcome everyone to Patient Monitoring webinar. My name is Seema Rathore. I am Senior Project Manager at Comagine Health and I'll be your facilitator for today's event. If you want to turn on your video, the button to start the video is at the bottom left part of the screen. Feel free to use the chat feature. The button for the chat feature is at bottom right of the screen. We will have discussion session after the presentation. Feel free to use the chat box to post your questions and we will make sure to answer them during the Q&A session. Before we start, I would like to go through the disclaimer. This session is being recorded. Anything you chat or share in the chat will be the part of the recording. The recording and slides will be emailed to all registrants. So let's start the presentation. We have 3 presenters today. One presenter will be speaking about remote patient monitoring, and the 2 presenters will be speaking about their experiences on these topics. Before we go to our presenters, I want to spend 30 seconds on this slide. So what is remote patient monitoring and why it is important? So in simple words, remote patient monitoring is monitoring patients' physiological parameters outside conventional clinic settings. If we think about it, it is an old concept. People used to bring their diaries with blood pressure, blood glucose numbers. Now monitoring has become more sophisticated. We have blood pressure, weighing machines with Bluetooth on it. We have vendors promising end-to-end transfer of data and so on. Our speakers will discuss this in more detail. During the presentation, I would like audience to think of useful outcomes of this kind of services rather than just checking another box. Some of this outcome includes provider and patient satisfaction, which is very important. We also know that CMS is trying to reduce cost per patient. We also know that big costs are related to emergency visits and hospitalization. And we also know that readmission and utilization can reflect negatively on your MIPS reports or in other quality report for hospitals. Research have shown that this type of services can help to reduce readmissions and emergency utilization. Actually, I have come across some hospitals who just pay for this kind of services to reduce their ED utilization or their readmission, 30-day readmission. It's been shown, there are some very good, powerful studies there. As the presentation progresses, I request please keep the various outcomes in mind. One more thing, this type of service is also an improvement activity for MIPS program. Even telehealth is being added as an improvement activity for MIPS program. So if you want to venture in this kind of service, you can add that to your improvement activity for MIPS program. Our first speaker is Lori Foley. Lori leads PYA's compliance service line and is a member of Value Transformation and Compensation Valuation Physician Service teams. She has nearly 2 decades of consulting experience in managing hospital-owned practices, advising physicians and organizations in area of compliance, compensation, strategic planning, operational and financial improvement, and affiliation structures. Recently, Lori has been immersed in assisting organizations with understanding the volume to value transition, population health management, deployment of chronic care, transitional care management, and remote patient monitoring services. our first presenter, Laurie. Laurie, floor is all yours.
Thank you, Seema. Good morning, everyone. Did you get a lot of feedback? Does that settle down? Very good.
Sounds better.
Thank you. So let's start for just a second looking at remote patient monitoring and talking about how we got here. The code 99091 was actually introduced in 2002 by the American Medical Association in their CPT guidebooks, but it wasn't until 2018 that CMS began reimbursing for that code. Historically, they considered it to be bundled into other services. Everybody was excited, but as we got the information and dug into it, we realized that that code required 30 minutes of the provider's personal time, that it must be initiated during a face-to-face visit, and that patient consent was required to be obtained. Obviously, given those requirements and the fact at that point that the reimbursement was about $60 compared to a 99213 that reimbursed at $76, it was hard for providers to determine that this was really a good use of their time. That 99091 was for the collection and interpretation of the physiologic data, such as what Seema was describing before, that was either digitally stored or transmitted by the patient. So in 2019, based on low adoption rates and provider feedback, CMS announced that it would reimburse 3 new RPM codes, remote patient monitoring codes. And you see those codes here, 99453, which is the initial setup, patient education and helping get the use of the equipment underway. 994454, which relates to the monitoring, the actual transmission of data. And then the actual provider services, 99456. And Seema, if you'll move to the next slide. Thank you. The structurally that was progress, but there was still some opportunity. And CMS each year, if you read the dialogue where they ask for comments and provide feedback, they got a lot of feedback related still to those codes. And so in 2020, they released, they modified 99457 and split it off so that they also gave us 99458. And really what they did was broke those up on time. So as you can see here, 99457 is for 20 minutes of monitoring, the initial 20 minutes of the activity by the provider. And then they gave us an option for incremental 20-minute increments or additional 20-minute increments. They have not yet, either in the narrative or in the rule, have they provided any frequency limitation on the 99458. We'll dig into each of those codes a little bit more in just a moment. It is important to know right now that these codes are not available for rural health clinic or federally qualified health clinic billing. But we are hopeful, chronic care management and transitional care management started off as being non-billable in the RHC and FQHC environment. So we are hopeful that these later get adopted. We know that COVID obviously has created some additional adoption in a short term, but hoping that they will carry that into the long-term adoption. Just quickly so you can see what those payment rates are. You see here are both the non-facility and the facility rates. So there is they have increased their reimbursement, but also by allowing some additional time that providers were spending to be billable, particularly with the 99458, that has made it not only available more reasonable for patient care purposes, but also for provider purposes. So talking, obviously, all services at the basis must be supported by medical necessity. And so for remote patient monitoring, it must be ordered by a physician or a non-physician practitioner. And the monitoring should be related to a chronic or an acute condition. And really, it's under the premise that the information that is obtained by the device is and transmitted to the provider is meaningful to the provider's management of that patient's condition or care. So it's not something that we can order and receive the information and count if it's just extra information or we're not actively using it in the patient's care for those specific diagnoses. And it's important to note what that purpose is, how it fits into the medical necessity, and why the provider uses that information in the documentation of the medical record so that it is available if the provider is audited. There are some technology requirements related to the devices that are used. So CPT 99454 states that the devices supply daily recordings, provides daily recordings or programmed alert transmissions. And so thinking about the alert transmissions, that's as if you've got set parameters. You expect the norm to be between X and Y. If the patient falls out of either end of that, then an alert is transmitted, or that it is giving daily respiration or giving daily weight in the case of COPD. CMS summarized its comments in the 2020 final rule seeking additional guidance, asking for additional consideration, noting that they plan to consider those questions in future rulemaking. But currently CMS, and we have not found any guidance from the MACs as well related to sub-regulatory guidance. So right now, the only thing that we can find that is definitive about what the device must do or how it must be characterized is the CPT indicates that it must be a medical device that is defined by the FDA, the Food and Drug Administration. We interpret this to mean, as far as the capabilities, that the device must be capable of generating and transmitting the daily recordings or the alerts that we talked about. So the reimbursement is intended for 99453 and 454 to reimburse for practice expenses associated with furnishing those services, and those include the costs associated with the device itself, its placement with the beneficiary, so that would be the time associated with bringing the patient in, training the patient on how to use the device, or even if it's remote, it doesn't have to be face-to-face, but training the patient on the use of the device, and then the transmission of the data from the patient that's gathered by the device and transmitted to the patient. Because this, excuse me, to the provider. Because this is usually not done by a practitioner, most of the time by a staff, it could even be done by a vendor. There is no work relative value unit assigned to it, which would be important if you are in a model, for example, that might have work RVU basis. Code 453-99453 is reported for the device setup in the patient education, and it's reported for each episode of care. The CPT guidelines define episode of care as beginning when the remote monitoring service is initiated and ends with the attainment of targeted treatment goals. It should not be reported if monitoring is less than 16 days. So for example, if the patient receives and is educated on the device, but no data is transmitted by the device within the month, then one would not bill for 99453. 99454 is used to report the supply of the device for daily recording or programmed alert transmissions over a 30-day period. And again, it also has that 16-day test. So for example, if a patient initiated monitoring on July 1st and it continued through September 12th, you could report 99453 in July and then 99454 for July and August based on time, making sure I have my months right as we do that, but you would not report it in September because September did not have that 30 days. So again, it would be based on the 30-day increments there. So CMS did not provide guidance on some of the required documentation or place of service. So what we did is look to chronic care management because that's the most probably there's a tighter correlation in how that was deployed and some of the mechanics of how those are executed. So with that in mind, we recommend that you bill the place of service as the location where the billing physician maintains his or her practice. The date of service for 99453 is the date on which the device is delivered to the patient, But remember, you can't bill it that same day because you have to know that at least 16 days of monitoring has occurred before you are able to bill that. So you would hold those claims for at least 16 days, make sure you've gotten the data, that the device is transmitting the data for the 16 days. Then you can bill the 99453 using the date that the training occurred. The documentation that you would include in the record includes the practitioner order for the device. Remember, we said that was required. The condition that's being monitored, the medical necessity of having that monitoring in place in the at the onset, identification of the device, data delivery to the patient, and the dates that the training is provided. Again, you're trying to put all of that in one place and kind of tie it up in a bow so that upon audit, you have all of those pieces there and you're not having to pull them from multiple areas. Documentation for 99454 should demonstrate the transmission of the daily recordings or alerts. So the device has been placed with the patient. It is monitoring on a regular basis. So it should be transmitting to the practice, usually through an app or a login, and you can see the results, the biologic results that it's doing. So you should have the documentation to show that you have received that for those 16 to 30 days, depending on what period you're billing for, and that's included in the record. The data service for 99454 would be the last day that the device records and transmits information if it is between 16 and 30. If it goes for the full 30 days, then it would be 30 days from the delivery date or the date that the training was completed, whatever day you use to bill that 99453. And then subsequent dates would be 30 days from that previous date, as long as, again, you have those 16 days of service. So remember, 16 days of service is going to be a common theme that we see through all of these. So 99457 and 99458 are for the treatment management. So this is the actual provider services. And as mentioned at the onset, 99457 is for the first initial 20 minutes, and 99458 is for additional 20 minutes within the same calendar month. CMS does switch there because before we were saying in 30-day increments related to 453 and 454, but here they are referring to a calendar month. So notice that transition. It does require live interactive communication with the patient during the month, but CMS has not specifically defined what that looks like. So we infer that a face-to-face visit would count, along with an interactive video conference, a telephone conference, or even a text message would allow for that live interactive communication between the provider and the patient. Effective January 1, 2020, they changed it so that it requires general supervision. So it is important to note in that scenario that it must be billed under the NPI of the practitioner who's providing the supervision, and that may be different than the ordering physician. So be aware as you're monitoring that, whoever's supervising the staff that are providing these services, that would be the NPI to bill this under. And again, we discussed earlier that there are no frequency limitations on 99458. And then remember to document that live communication in the medical record. Again, just tying it all in a bow and having that all in one place. CPT guidelines do provide some additional clarifications, again, all subject to medical necessity. The codes may be reported during the same service period as chronic care management, CCM, transitional care management, and the behavioral health integration services. There were periods of times where those services in particular were exclusive to one another. You could not bill, for example, chronic care management and transitional care management. Originally, it did eventually change during the same period, but we do not have those restrictions with remote patient monitoring. Similar to those codes, however, we can't double count any time. And so if you have a circumstance where a provider is seeing a patient and providing an E&M, then we can't count any time from that day to support these codes in those 20 minutes for the initial and the additional 20-minute increments. And this is not including time related to any other service. So whether it's a visit or some of the other codes that the other speakers will talk through, it has to be dedicated just exclusively to 99457 activity and 458. You can count, again, right now, the CMS was silent on specific guidance related to these. So we are again taking from chronic care management. We feel like that is a defensible approach, that you can aggregate time that is spent on different days or time that is spent by different clinical staff members within the same calendar month in order to achieve those 20 minutes. If two staff members, however, are talking about a patient, or the provider and the clinical staff are discussing the results of the patient and what to do about it, you can't count the time for both members. You take the clock time and you only count it once in that scenario. And then time that is less than 20 minutes cannot be rounded up. So if you achieve only 18 minutes, you can't round it up to 20, and time can't be carried forward. So if you spend 25 minutes and it's not enough to bill a 99458, you can't take that 5 minutes from this month and carry it over to next month for billing purposes. So Seema, I'll turn it back over to you to introduce Scott.
Yes, thank you, Laurie, for a wonderful presentation. So just to summarize what Laurie said is remote patient monitoring, which has 3 to 4 codes. There are, first code is just, there's one code just for equipment, then code for setting it up, and then other 2 codes for providing services. The one thing to remember about remote patient monitoring is that it's end-to-end electronic transfer of data. So this might require for you to either work with your EMR vendor or just a third-party vendor, but very useful for patients who have chronic disease, something related to cardiac issue, something related to diabetes, oximeter monitoring, weight. So the way you can start this service is see who are your frequent user to ER or to for readmission. If it's cardiac related, just narrow it down. That would monitoring them like this would help to reduce their visits and in general for a good health of a patient. So something to keep in mind that yes, this service you can implement, but at the same time there is something related to gadgets and some electronic way of transferring is needed as well. Our next presenter is Scott Conroy. Is currently the clinic administrator for Hillsborough Cardiology and Center for Vein Therapy. He has had many roles in healthcare management in more than 40 years in Portland, Oregon area. He has worked in the Providence and Legacy system as well as in several joint ventures of medical groups and hospitals, focusing on system reforms and triple aim initiatives. His greatest joy is his marriage of 45 years, 4 children, and 15 grandchildren. He serves on board of Clackamas Women's Service and several committees of Comagin. So something while we are talking about Scott, because he's from cardiology, he has a very good experience of implementing this kind of services, what it takes for a clinic to implement something like this. It could be a very big lift for a clinic which does not have a good infrastructure, whereas it could be a small lift for a clinic which has a good infrastructure. Scott, it's all yours.
Thank you, and welcome everybody. Good morning. I hope my feedback loop isn't too bad. It's great to be with you. You talk about a major time of market disruption that makes this a timely topic. In evaluating any kind of new service, be either here at cardiology or in my former positions, one of the things that I've increasingly tried to do is use a model of evaluation and decision-making as you put together the business. It's one of those things that if you can remember one thing, it is how do we make decisions and how do we make that happen well. I've always begun, or not always, but I've recently begun to try to use the IHI triple aim. How do we improve the patient experience? How do we improve population health? and how do we reduce the admission, or how do we reduce cost per member per month as part of the evaluation model for everything that we do. And in this case, some of that is fairly self-evident, but some of it is going to be challenging as you move forward. Of course, we can perhaps improve the diagnostic monitoring. We can improve the patient's sense of comfort and low travel requirements. Those of us doing telehealth have found that that is very appealing to some of our patients. Improving the population's health may be a better, bigger challenge. Do we really improve diagnosis and medication management with remote patient monitoring? That is, as we'll hear later, going to be as much an art issue as it is a data issue. And then reducing cost per member per month. Most of us are in alternative payment methods or risk sharing. Most of us in cardiology are dependent upon primary care physicians for referrals. And increasingly, they don't like the idea that we spend their money without good cause. So I urge all of you to use this kind of a decision system to take a look at what you're doing. Okay, next. And I'll try to move along here in my talk outline also. Barriers and learnings. Seema asked me to say, what are the barriers and what are the learnings that we've had? And I always use this and put this in our decision model also because it helps to identify these things as you look at any decision. Staff training, provider reinforcement of the staff training, retraining of staff and patients as staff evolve and production systems evolve, system changes that occur as a result of market disruptions. In our case, for example, we did all pacemakers in-house until the 1st of March. Now we do all pacemakers in terms of their reporting and so on. We do them all remotely. It's just such a using those market disruptors as a incentive or as a motivation for making changes. One of the things that I always try to incorporate in our decision models are what are the patient training, patient experience in terms of, are you really addressing the multiple learning styles that patients have so that you can get their not only compliance, but their support and buy-in for what you're trying to work with them to accomplish. Something that we in healthcare have not done very well on is recognizing those learning styles and making that part of our decision-making and implementation. Go ahead. Next, yeah. Choosing a vendor. Part of our decision style here has been, well, what does the vendor present? Part of what we want to move to is what are we looking for? What are the diagnostic capabilities that we need? What will the patient acceptance of these be? The cost effectiveness, of course, the cost per member per month, the patient's out-of-pocket expense, and then provider confidence in the tool. And let me kind of revisit with you. We do something called the Zio patch here, which is a 14-day monitoring device. We have started working with patients in terms of their out-of-pocket expense prior to putting it on or having them put it on. We find that about 10% of the patients will choose not to put it on because of their out-of-pocket exposure. And that out-of-pocket exposure can be anywhere from $20 or $30 to hundreds of dollars, and patients will make that decision to not go forward or to go forward. And it's very interesting that they will make it for $20 and they will make the decision to go forward if their out-of-pocket is going to be several hundred. But one of the things that we try to do in terms of that patient acceptance is to actively engage them in that cost-benefit decision. Okay, next slide. We can come back on these. Initiating the service, some of the things, again, in our decision model, we try to always look at how do we start with a low investment. We'll talk about piloting here in the future or in subsequent slides. And recognizing that each technology has its own investment need, but you need to be very, very careful that you identify all those investment needs, not only in terms of financial resources, but human resources and system changes that need. We always try to start with loaned, leased, used, or borrowed equipment to test something out. We do vein therapy here. We borrowed some equipment to see if that was going to work for us. We also try to focus on a single pilot concept using a provider champion and a few staff champions as early adapters. Getting a whole physician organization to move en masse to a new technology is, I think, unbelievable, and I've never been able to get it done well. Always, the better approach has been a single pilot concept so that you can develop something and develop your systems, get some key buy-in and championship. One of the things in terms of your investment that you always have to look at, and especially as you're putting together your pro forma, is the time it takes for concept development and staff training, retraining, and refocusing. Don't understate what it's going to cost, both in terms of that, those human kinds of efforts. Okay. A key is, of course, always having a provider champion. And I know I'm talking to groups that are both hospital-owned as well as independent, and other groups also. But what I have found is that new technologies or new systems always require a clinic champion as an early adopter, because part of it is they're the decision makers, part of it is they're the owners, part of it is they are the people who have been socialized and trained to be those in charge. And they're also the recipients of the information and the ones most likely to be interacting with physicians or patients. So again, having that provider champion is really important. And again, different clinicians will be early adopters or champions based on their interest and bandwidth. With the provider champion, don't forget to use staff champions also. Again, you want to look for people who are not afraid to change, and we'll talk about that in a few minutes. Return on investment is always something that, as an old finance trained person, I always get a kick out of developing pro formas. Whenever you do a return on investment or pro forma, you're rarely accurate. Your volume projections are often wrong, usually too high. Sometimes you're too high based on provider confidence and perspective. Sometimes you're too high based on what a vendor says is going to happen. Revenue per case, don't forget case mix is huge. And we have found that out in some of the things that we've done here. What we think of is going to be either very unsuccessful or remarkably successful turns out to perhaps be completely different based on that case mix. Expense evaluation, especially provider and staff time, we're usually not accurate. And so I always use the perspective of taking a good spectroscope and were your assumptions correct? Does the data support break even in and of itself? And then from an anecdotal or art perspective, is the effect on population health and or quality of the patient experience positive? And again, your physician champions and staff champions, as well as patient input, will drive you in this regard. Don't forget to ask the patients what they think. Okay. Some of the upfront requirements. Clinician, I'm sorry, let's see if I can get rid of that. Clinician champions are really important, and especially their ability to tell the story to the rest of their colleagues. Staff champions are the same. Give your systems a good try and then fine tune. I have never implemented a project or a new technology and found that it worked well right out of the box as well as it could. Working with staff that like to do something new and important as the first people trained is important. Having that culture is just really, really important. Don't be afraid to relook at the value added in each step of your system, Kaizen system, Kaizen methods or whatever. Asking the question, is this step necessary? And again, I can tell you stories of how we've gone to adopt new technologies that used to involve many staff, say 5 or 6 staff members along the way. And we've now come to the point where actually it's done with 1 phone call rather than 7. So don't forget to look at your systems and look at that value added issue. Medical groups, and ours is one that we still do at every workplace I've been in. We sometimes adopt the phrase, if it works, don't break it. I think part of that needs to keep moving. Yes, if it works, don't break it. But on the other hand, always trying to improve is something that gets us forward. One of the things in many years, and I now use this whenever I talk with groups and even our group internally, is if we are looking at resistance or something that's not going to work well, we begin to talk about our fear. And why is that fear up? Sometimes it's a fear of failure. Sometimes it's a fear of being held out as to be incompetent. Sometimes we're afraid of being scorned. And sometimes we're afraid to commit. That we're afraid to commit to something success. So I implore all of us to keep looking at that as one of the things that keeps us from succeeding. Okay?
Thank you, Scott, for your insight. So the purpose of Scott to bring in this presentation was to just give an overview of how to start a service. And is it even worth for you to do an investment like this? Nowadays, vendors are not the low-cost vendors, very complicated work if we think IT-wise. So something to keep in mind as you are making decisions. Our next presenter, Mindy Willits, she has a bachelor degree from Southern Oregon University in Business Administration. She has worked in the medical field since 1987 and has been with Medication Clinic based in Ashland as a manager for 10 years. So Mindy's presentation is a little bit different in the sense that in the beginning, if you don't want to go through the remote patient monitoring, the codes which Laurie spoke about, which requires end-to-end electronic transfer of data, if you're not ready for that kind of commitment, Mindy is going to talk about something which has happened this year, some new codes, which does not require that level of commitment, but at least you can start with something. Mindy, it's all yours.
Great, thank you so much. It was kind of fun listening to Laurie's presentation because she made my mind think we might be missing out on some reimbursement in my clinic. So thanks, Laurie, I appreciate that. The self-monitoring blood pressure codes that SEMA has up there, those codes aren't something that we actually utilize a great deal in my office. I suspect we probably could, as many offices can. So I won't be able to sound intelligent on those first 2 codes at the top. Specifically at my office, the 93042 and the 93793 are something that we actually do frequently. And I suspect a lot of clinics also spend the time doing what the provider, the time that they're putting in, but not billing for it. And so on the interpretation of a rhythm strip, we have a handful of patients who have home devices that they use. And occasionally they'll have what I'm going to call a cardiac event. And of course, they're not at the office. So they have at their home a device that they've purchased. And when they contact the office and say, hey, I have something going on, my doctor says, okay, go ahead and start recording and then forward the report to me. That report comes into us, and then my doctor interprets that report, and that is when, and he generates a brief report based upon his interpretation, and you can bill for that code. And again, I think offices might be doing this, but just not billing for that time. And so I think there's some reimbursement that you might be missing out on for that service. The anticoagulation management code, it's big. If you have a patient on Coumadin or warfarin, anytime they have their pro time drawn and the information comes back to the office, the doctor has to look at that and interpret that. And if they're within a normal range, then of course, either he or myself will call the patient back and say, hey, your INR is 2.0, great job. Continue taking your Coumadin as prescribed, recheck in 1 month. So anytime the doctor takes the time to interpret the numbers on a lab draw, again, you can bill for that. And in my office particularly, we do it by keeping an Excel spreadsheet in our patient EMR. And anytime my doctor reviews a lab result, he enters that number in that Excel spreadsheet, says, indicates when he wants to recheck. I usually call the patient and tell the patient, what the doctor's orders are. So I typically bill this on a 30-day increment. Part of the reason for me doing that is because if for some reason a patient takes their pro time draw, comes into the office later that afternoon for an office visit, I can't bill for the interpretation. It's bundled in with an office visit code. So you just have to be patient and keep a flow sheet and bill it accordingly. So again, particularly the anticoagulation management interpretation, doctors do it all day long, every day. And if you're missing out on reimbursement, it's definitely something that you should think about for billing purposes.
Thank you, Mindy, for such useful information. A very quick just overview of 99473 and 99474 self-monitoring codes for blood pressure. These codes went live this year. 99473 is basically a patient will bring their home monitoring blood pressure device home for validation from a clinic staff. That's the time spent by a provider or a clinic staff. They would bill 99473 code. And 9947 is for once the patient takes that blood pressure machine home and then records. I believe it's 2 recordings every 2 minutes. And then they bring back those numbers, and provider or support staff, they read those numbers and make the adjustments and medication, whatever time they spend. That is the second code for that. So in this code, there is no end-to-end electronic monitoring is needed. And that's why I thought this was important. If someone is not wanting to make a big commitment of going through a vendor or committing to their EMR, something like this small to start with would be a good option. And also, like Mindy mentioned, so much money is on the table, and we are realizing that practices are not using this money. So why not to start? And very important thing is that by using all these codes, these are the way you are telling to CMS or your payers, hey, my patients are sick. I am spending this much time. That's why documentation is very important. And that's how CMS or payers allocate the amount of money per patient. So it's very important to let, especially for CMS, to know that how sick your patients are. And these are the various ways, including documentation and SCC codes that they do the analyze on the backside. So now we are open for questions and discussions. Gwen and Trudy are helping us with the chat. Do we have questions there, Trudy? If you're,
This is Gwen. I think Trudy's having a little bit of internet problems.
Okay.
We do have a question from Marie Hamilton,
Mhm.
and it's my understanding from CMS is that for the 99454 to be billed, the device must be able to transmit the readings electronically via Bluetooth enabled. Is that correct?
Laurie, can you take that question?
Sure, and I agree. CMS in their 2020 comments indicated that there are a lot of questions related to the technology. At this point, they have identified that they are going to address those in future rulemaking. I know they did release an FAQ that caused some questions, but there are devices that transmit via cellular in addition to Bluetooth. So I have not seen any definitive answer on that one. It's still in the gray area.
Yeah, and recently someone else reached us out for a similar question. And what we were told was, if your Bluetooth, if you have some kind of app in your phone, if your Bluetooth can talk to your phone, if your phone can talk to patient's portal or any vendor, and if you're transferring your data like that to the provider or to the practice or wherever those are going, then yes, it's end-to-end electronic transfer. The point is that not having any manual entry in anywhere in this step, but it creates such a complicated process to going through so many different apps and patient portal. But I know that there are some big EMRs which their patient portal interacts with some Bluetooth gadgets, so it reduces few extra steps.
Right, and if I could for just a second, Seema, because I had made a note just to follow up.
Sure.
Thinking on that end-to-end piece, as you describe it there, I totally agree in that it has to be electronic. So it is not that the patient weighs themselves, they write it down on a log, then they scan it, they snap a picture of it, they do something like that. They weigh themselves, the device captures their weight, summarizes it, and sends it to the provider so that that's coming from an electronic piece. I want to make sure we don't confuse listeners today from a end-to-end description as in meaningful use. So, some of the meaningful use bonus points or the promoting interoperability bonus points where it has to get all the way into the formal EMR. We're not talking about it in that context today.
No. Yeah, anyone on the discussion board have any attendees have any insight for this question? We do get this kind of question quite a bit, or any experience. You can unmute if anyone wants to speak.
Seema, this is Gwen. We have another question in chat from Celinda Amos. Does the 93793 code work if we are monitoring the INR through a home health company?
Mindy, would you like to
Right.
take?
Well, I'm going to say I don't think so, but and I'll tell you why, but I could be wrong. I don't have experience with that particularly. We currently have a patient who is status post hip fracture, kind of homebound. And so of course has home health coming in and doing the blood draws for the pro time. The person goes out, they check it, they do the blood draw. My doctor gets the report, my doctor interprets it. So he bills because he is interpreting the number on the pro time. So I don't know if a home health person could charge it. I mean, I don't think you could, because they aren't interpreting it, they're simply drawing the blood.
Thank you.
So Lori, can I just add a follow-on question to that? So if the home health company was obtaining the INR and sending it to the PCP would be able to use the 93793 even if the home health company was not. What do you think?
This is Lori. I'm actually going to give that to Mindy because I think she was answering that previous question.
Right. So here's what I think. I think that the home health agency can charge for the draw. That would, and I don't even know what that code is, to be honest with you. but it's my doctor who is interpreting the result, and that is what that 93793 is. It's the interpretation of the number.
Thank you, Wendy. Gwen, do we have more questions?
We don't have any more questions in chat.
I have received some questions in my email, and also some folks asked me to ask these questions. So those codes are for CMS for remote patient monitoring. How about other payers? Are they supporting this kind of service at this time? How does that work? Lori.
Usually where Medicare goes, the other payers go perhaps at different paces. Where we do see a lot of interest in adoption is particularly in the Medicare Advantage plans, and for the reasons that you outlined at the very beginning, Seema, and I know Scott, you and I, we've had some conversations related to lowering the patient's cost of care and eliminating readmissions. And so we do see interest in some of the care plan, the programs that those insurers are launching include remote patient monitoring.
Okay, yeah, thank you. I do have this question for Scott. Scott, I do help several practices, helping them choosing a vendor for different kind of services. Do you have any tips on how to negotiate? In past, I have felt that with a good negotiating skills, we're bound to get some good prices.
Well, it depends upon, Seema knows that in one of my former lives, that's what was my job, was to negotiate. And part of that is always know what you're trying to negotiate for. For some of the things that we do, we aren't buying the machine. In other cases, we are definitely buying the machine. And I always try to work with people and work within our own group, for example, and say, what are we trying to accomplish? And is there some way to accomplish that with the vendor that can be mutually beneficial? I'm not out to have a vendor not make money, but I also want to protect the organization as we move forward. And I can give you examples of overestimating or underestimating what your volume is going to be, and then using the vendor to help you with the acquisition of the technology, if that's what it takes, to mitigate that risk. And most of them will do that, in my experience. They're not afraid to go at risk with you for the purchase price or use other kinds of financial arrangements. And that always gives you a bit of an indication about how confident they are in their own estimates also. Because if they are saying you're going to do 500 of these a year, and I'm saying, okay, fine, but are you willing to be at risk with me in the acquisition for anything between 250 and 600, and they back up and say, no, well, and I'm not sure their 500 estimate of annual volume is accurate. Negotiation is an art. Don't hesitate to ask, though. I'm amazed at how many people never even ask what the purchase price is, but also ask them what it would take to get a different purchase price. That kind of getting to yes negotiation has always been more successful for me than just trying to hammer them.
Yeah, and especially for remote patient monitoring, there are several vendors. And in my experience, we can't endorse any vendors on this call, but in general, the vendors, they have several different packages. For example, there would be a vendor who would just have a package with blood sugar monitoring or with some blood pressure. Some vendors will have package with blood sugar, blood pressure, and including the device. And the cost varies with all those different packages. So you really want to have look into your patient population on what your need is and what are you trying to do, and to make sure that a vendor with a good communication and they have good customer service.
And also, one additional item, even if they're telling you that your clinic's out-of-pocket or expenditure for the equipment is going to be low or zero, you also need to remember that in some respects, you're negotiating for your patient and for the payer. And if you take that perspective, recognizing that you have that kind of responsibility because you're going to be the driver, your then the receptiveness of payers or patients also goes up because you can say that you did good due diligence to make sure that this is the most cost-effective, efficacious technology available. That goes a long ways with medical directors from health plans.
Mm-hmm.
And I think, Seema, if I could add, I think the other piece of that, there are circumstances where if a patient has a question or the device, you know, we've all had those where they're supposed to be plug and play and there's questions and you need assistance getting it launched. And likely they're calling that vendor for that support, not necessarily your team and your staff. It depends. You may get them both ways, but that customer service vetting, I think, will be important in that regard as well.
Yep.
Yeah. So, Laurie, for remote patient monitoring, is it required to monitor during the weekends or is just Monday to Friday? How does that setting work?
It just depends on the chronic condition being monitored and the physician's preference and the type of device. The use is so varied. You know, really, you're looking for the number of days within the month, but I've seen applications for different diseases where they are just doing it during the week. They might be doing it heavy loaded, you know, skip a week within the month, depending on the protocol of what they're trying to manage and monitor. So that is not prescribed necessarily by the code. And, you know, is it 7 continuous days or is it, you know, skip the weekends or only do the weekends? It just depends on the needs based on that medical necessity.
Mm-hmm. Okay.
And patient convenience and patient adoption, because that's the vendors that I've spoken with that are looking at these codes are having to really weigh in how much are we really going to be able to ask the patient to do that they would comply with and therefore make it beneficial.
And the 20 minutes is including staff time if they are looking into the updating medical record or anything would?
Yes. Yes,
Okay.
or asking the clinician questions or calling the patient to say, okay, let's, you know, it looks out of whack today, let's take another reading or those kind of things. All of those add in. One thing I didn't mention, I did stress the 16 days, but under this COVID emergency, if you are monitoring a patient for a COVID related concern, then it is allowed to be less than 16 days. It has to be more than 2 days, but at less than 16 just during this COVID situation.
And just for COVID patient or any patients?
It has to be related to a COVID concern, a COVID diagnosis or the suspected COVID. If you're monitoring them for, you know, other diseases, other disease states,
Right.
that would still have to continue.
Okay. We have Laurie, we have 2 minutes left. Just in less than 1 minute, how about skilled nursing home patients? What is your experience in that setting?
I have not seen it as widely. I've had a lot of inquiries related to it in skilled nursing, but would want to do some additional research before giving any particular guidance on that. I'm mostly approaching it mentally from the medical practice perspective.
Okay, great. Thank you. There is 2 minutes left. So we have, Comagene has created several, has collected information on telehealth, payment requirements, and lots of information. It's on our website. We encourage you all to go to the website. We also have a help desk. You can reach us out if you need any help, support in any kind of telehealth. I would not say just telehealth, any kind of help, just reach us out and we'll try our best to help you all. Here is my contact information. I would like to thank our 3 presenters today and you all for your participation. I hope that you all were able to benefit from their valuable insights. I would also like to acknowledge my team, Bree, Gwen, Trudy, and Paige. Do we have any last minute 30-second question, Gwen? So it looks like we don't. Okay, so my contact information is there. If anyone has any question for the speakers, please send me an email. I will contact them and get the answer. That is all for today. We will sign off for now, and we hope you have a great rest of the day.